think we can begin. My name is Daphne. I support Ocular with communications and engagement. Once again, thank you for making the time to be part of this discussion. So the brief agenda is introductions of the two speakers, Dr. Rose Nakasi and also Dr. Alfred Andama. And then we will get straight into the first segment of the discussion, which is basically the importance, first of all, of diagnosis in the healthcare system, in the healthcare ecosystem. What's so crucial about it, and then what are the challenges that are faced currently in Uganda as a resource-limited country and elsewhere in the world. And then we will go on to the opportunities and challenges or new solutions for diagnosis, whereby we'll discuss primarily Ocular solution in automating mobile microscopy, automating diagnosis. And yes, so after that, we'll just have a brief Q&A for anyone interested to share insights or any questions that you may have. Yes, so I'm going to kindly request Dr. Rose to just give us a brief introduction of herself and also a brief context of what exactly it is Ocular does. Then thereafter, we can have Dr. Andama dive into the issue of diagnosis in healthcare. Thank you. A kind reminder to just keep your questions on hold, keep your mics on mute for now. We will definitely have a moment where we can unmute and share our insights so that we can get the discussion.
We are all aware for anybody who feels ill health and seeks treatment in any health facility. The first thing the clinicians will want to do is to establish the cause of that illness. And in most cases, especially when we are dealing with infectious diseases, and even in some cases, non-infectious diseases, there's need to establish a diagnosis in order to plan management for that patient. And so, therefore, any early and accurate diagnosis becomes so crucial in order to guide the choice of medicines, the course of treatment, and actually monitor that treatment as the dose is being taken. And so, if you make a wrong diagnosis based on wrong tools, this can result into administering the wrong treatment, thereby delaying the cure process and eventually complicating that illness. We have seen cases where somebody comes to a hospital with a fever, and because we assume every fever is associated, for example, with malaria, even when we also know that some bacterial and viral infections can also cause fever, we end up over-treating patients for diseases that they do not have. And so it becomes very crucial to be able to find alternative ways of making the diagnosis more appropriate and also be able to pin down the cause of illness and thereby have a targeted treatment that could easily result into cure of that patient. And in so doing, trying to establish diagnosis, it becomes costly, especially to the health facilities, to the government. You're spending a lot more money trying to establish a cause of illness when other sectors within the same health system are being compromised. And so, therefore, having a method that accurately, makes a diagnosis becomes very, very important. We have different diagnostic tools on the market for various conditions in health. But each one of them has a limitation, including when you talk about AI, there are some instances probably when they become limited especially if they require additional infrastructure, which the facility may not have. And so automating, especially now the microscopy in this case, solves a couple of problems. When we have limited number of lab techs around the country doing the basic diagnostics, nowhere in a tropical world, sub-Saharan Africa, where we have lots of infectious diseases, and our main diagnostic tool is still the microscope. And so lab techs usually spend a lot of time trying to examine different slides, different smears for diseases that are suspected. So if you have, for example, one lab tech in a facility that sees on average, say 100 patients in their OPD, the microscopist might want to spend on each slide on average maybe 10 to 15 minutes. And if he does that, other specimens for patients who have come with the intestinal pain, and maybe they have parasites in their abdomen, those that have come, for example, with the chest complications requiring TB testing are still in the waiting. So many specimens, one lab tech. So if you automated only one aspect in microscope, you will save a lot of time, which the technician would deploy for processing and analyzing other specimens. So this long time waiting for patients usually results into a failure to pick these results. You lose a patient who has a disease because they got frustrated by overweighting and left with their disease. And if it is an infectious disease that can be spread to other patients, they end up spreading it continuously in the community. So the other challenge, the other problem associated with the delayed diagnosis will be a possibility of drug resistance development. If a patient, for example, comes to a facility and fails to get diagnosed easily, and therefore decides to go to a pharmacy which sells medicines across the counter, they may end up buying the wrong drug. And most times patients behave in such a way that if they are unable to get a relief in a short period, they believe this treatment is not working. Then they change into another one. So suboptimal use or misuse of these drugs usually perpetuates drug resistance development. We know a lot of drug resistance now world over. That is, one precipitated by other factors, but more importantly, diagnostics become very crucial, especially in trying to identify the right causative agent and thereby directing to the best options for treatment possible. And so when we look at microscopy and look at automation, it gives a kind of like standardization that if we see this, then this is likely the right cause, other than the subjective way sometimes of misinterpreting an output from a microscope. So as an overview, Chair, I think I would want to stop here unless at some point when some questions become relevant, then I'll be happy to respond. Also get views from those who are in attendance on how we could actually embrace an automated microscopy in our settings. There are certain things, there are certain aspects of treatment costs that up to today, especially in our country here, we have not given to other testing platforms. For example, if you identify the patient who has TB after treatment for 2 weeks or so, we want them to come back and we see whether they are responding to treatment. We know we have a molecular the more sensitive tests that can actually be able to pick that. But they have limitations because their design requires that they pick certain aspects of the causing organism. And whether the organism is still living, causing ravage, or is already, disintegrated, is no longer causing a problem to the patient, it will just say this patient is still positive. Ideally, you are supposed to either change treatment or increase some kind of dose. But microscopy is still now relevant in that case. You are able to see that actually this is the causing organism. It has not changed form. It is still the same thing. So the Minister of Health, in wisdom, has recommended still microscopy for patients on follow-up for certain diseases. So automating it helps in relieving time, in cutting time, making sure the patient complies with the treatment regimen. Thank you, and back to the chair.
Thank you so much, Dr. Andama, for giving that elaboration. I'm going to share my screen to kind of give you participants a visualization of what exactly the Ocular solution is. But Dr. Rose, I want to kindly request you to, one, introduce yourself, the work that you do, and secondly, some context for Ocular, and then why it's crucial, or why it's something that's useful right now to microscopy and the issue of diagnosis. Thank you. Dr. Rose, are you there?
Yes, I am here. Can you hear me?
Yes, we can.
A bit of a challenge with the network, I think, where I am, but I'm glad that you can hear me. My name is Rose Nakasi, the principal investigator for Ocular project. I am a lecturer at Makerere University. It's an opportunity for us to have a conversation on the use of artificial intelligence in health. I am very grateful that Dr. Alfred Andama has given ground and given us the context, especially in microbiology, around the use of microscopy for diagnosis of diseases such as malaria and all other challenges that are diagnosed microscopy. And as Dr. Alfred has put it, the challenge out there is actually the lack of enough trained personnel like him to be able to carry out the gold standard mechanism of some of the challenges that we have talked about, including malaria. So our idea is that some of these gadgets, especially the microscopes, we have them at the different health units, but the major lack is for the trained personnel. So we wanted to find a way of how we can infuse artificial intelligence or computer vision to be able to support the routines at the microbiology lab. And these equipment, for example, the microscopes, according to a study that was carried out in Ghana, we realized that actually there are more sometimes microscopes at different health facilities than there is pathologists or microscopists to be able to carry out the diagnosis using the microscope. Also on market, we have technologies such as smartphones, even in highly endemic settings like Uganda. So we can be able to leverage on the smartphones which are available, as well as the microscopes, and as well as new advancements in technology such as artificial intelligence to be able to do image analysis. So our idea here was to be able to attach a smartphone onto the eyepiece of the microscope so that we can be able to capture images as they come from the microscope onto the smartphone. And the idea was, can we be able to focus, to have a focus of whatever that is passing through the eyepiece of the microscope to come directly onto the smartphone, so that examination can be made a lot easier without having the technicians to strain their eyes as they are looking out for these pathogens. And that is the birth for Ocular as a project, because Ocular literally means at the eyepiece. So if interpretation is done at the eyepiece, can we be able to leverage artificial intelligence to support the diagnosis of diseases? So our proposition was, can we be able to capture these images? And I think, like Dr. Alfred has told you, together with the team at the College of Health Sciences, we were able to curate a good number of examples, or a good number of smears, and we digitize them. And then once we have a characterization of the object of interest, and in this case, the objects were those that speak to the microscopy task that was at hand. And I think he has also given you an overview that we started with malaria, and now we're spreading out to different other diseases like TB, intestinal parasites, and cervical cancer. This is in here a typical example of the images that we curated. And those are the ones that contributed to our data set. So we have run different artificial intelligence models from the time of inception. We started off with the shallow machine learning, and now we are trying out the deep learning models. And this is part of the results that we received. So you can see that for one of the evaluation matrices, which is this convolutional neural network model, we had a good classification accuracy. For malaria, it gave up to 1%, which means almost 100% detection was realized. We wanted to translate that and generalize that for other intestinal challenges like TB. And again, the artificial intelligence model was performing quite very promising. We have done this as improvements are going on. We started with the shallow learning models. And again, you can see that improvements keep on happening with the new artificial intelligence models that we're trying out. On inference onto a test image, you can clearly see that we have the red boxes, or the red bounding boxes, are those that are representative of the detections that were made by the model. And the white bounding boxes were the validations that were given to us by the experts at the College of Health Sciences. So intuitively, you can be able to see that the artificial intelligence model is quite performing and is able to capture all the malaria parasites on the left. So those are the examples of the plasmodia that have been detected by the model. And again, the generalization of the solution was to the TB bacilli. And again, you can see that the model is actually performing quite very well vis-a-vis the validations that were given to us by the experts. And this is quite a very promising venture that, again, without having the experts to be able to strain their eye, the artificial intelligence model comes in handy to be able to give inference on the different patients. What this then means is that patients can get results very fast with a bit of consistency in accuracy. So at the end of the day, we anticipate that there is going to be a high throughput of the number of patients that are going to be screened in the day vis-a-vis what has been happening manually. So what is the journey, and how has the journey been for the project? Is that we have been able to curate a big data set. We started off in 2014 with a smaller data set of around 2,503 images that were annotated. And right now we have a bigger data set. We keep curating for different data sets, as you can see. So the more the data set grows bigger, the better the improvements for the models that we are training. And that means that our models get wiser and more accurate onto the different data sets that we're going to be giving them. And like Dr. Alfred has told you, we're already carrying out pilot from all the different healthy facilities. And this means that we shall have an inference on the different microscopy tasks in the different regions, so that we can be able to understand the state of microscopy in the different regions in Uganda, so that at the end of the day, we are able to come up with a solution that speaks to the different regions, but as well as to the different microscopy tasks, be it for malaria, be it for TB, and be it for cancers. Like Dr. Alfred has told you at inception, our task was to just look at just detection of parasites as a proof of concept that the artificial intelligence model was able to do that. Then we scaled it out to other microscopy tasks to see if actually the solution can as well infer well to tasks like tuberculosis. So the example you're seeing here is a good example of a generalizability aspect for the models on TB to detect TB bacilli. We've also done a scale out to look at other tasks of microscopy, for example, parasitemia determination, which is quite a tasky job for the microscopists, as they have to count parasites and they also have to count white blood cells to infer a correct quantification of malaria in a patient. So with this solution, we believe that this will come in handy to be able to support the identification of the parasites, the identification of the white blood cells, as well as quantifying them and inferring a correct parasitemia so that the right medication is given to the patients. Right now, we are in a phase of actually scaling out to now the thin blood smears, where we shall be looking at species identification, life stage identification, so that we are able to give the correct diagnostics around microscopy for the different challenges. And in this case, I'm speaking to malaria. We've also been able to now infer the detections onto the smartphone. So the idea for us was, can we be able to have detection done, to have the smartphone be able to capture the phone as well as infer a detection. So a mobile application has been developed to that effect, as well as a web application, so that in scenarios where we don't have an expert to give the final diagnostics, the image can be uploaded and inference can be given by the model. But for the mobile application, we believe that our infrastructure sometimes does not allow us to have good internet connectivity. Like right now, I've been challenged with internet connectivity. So in case that is the scenario, then we have an offline application that is able to infer a diagnosis. For that, we have been able to achieve all that, and that gives us an insight into what we'll do. But we just be able to correct diagnosis, that practices for treatment, as well as relieve the practitioners to spend more with either doing setting, so that it's that at the end of the day we have good healthy outcomes at the different healthy features. And that in turn patient change as well as compliance, and that is number 3, which is good health for all. Good advancements are going on. We are still faced with different perils, and these are the ones that we want to consider moving forward. As we develop
from about 2014, the team from the computing, where Rose and others have been working at the Artificial Intelligence Lab, joined hands with us at the College of Health Sciences to look at ways of trying to use their kind of research methods in improving health. And we agreed on to pilot this in 3 diseases, starting with the malaria, tuberculosis, and intestinal parasites. So the team came up with an application that should augment microscopy, especially at the point of examining smears. So our initial studies were looking at some slides that were already examined at acute care unit in Mulago. And we picked these slides, we asked for an IRB waiver because these were slides that were destined for discard. And we trained that particular application on how to recognize malaria parasites. We had some experienced microscopists in malaria who annotated, like marked the parasites on the smear by examining them physically. Then after rounding them with some boxes, then they were able to train the application to be able to pick. So over time, this application was able to pick malaria parasites with the great accuracy. So when we scored on malaria front, then we also moved applying the same principles for tuberculosis. Then eventually we went into malaria, to intestinal parasites, those whose diagnostic structures could be easily found in our settings. So we have accumulated images over time to be able to train this application even better. Now, what we reached now a moment, now we wanted to see at an advanced stage whether we can be able to test this application out in the field, where most of these patients with the malaria usually present at the community level. So we got some support from funders. Now our current approach is to try to see, with our first disease, the malaria, whether we can move to health center level 3, level 4 at a hospital and share this idea and ask a buy-in from these facilities, including the administrators, to see if we can start testing this application. So it comes, as you may see in some of the pictures that definitely sharing, this application is like any other app that we use on our smartphones. Like, let's say WhatsApp, any apps that can be loaded onto this the smartphones. So once this app is loaded on the smartphone, we've designed an adapter which can be attached to the eyepiece of the microscope. Then once you get a field of focus, on a click on that application, it is able to do the scanning, like the examination. We usually do the battlement or the horizontal movement of the field of view in order to identify the structures of interest. So that aspect is what we have tried to automate. And we think if this can be embraced and adapted, then we can be able to, the microscopist will do the smear, will do the staining, and once mounts it on the microscope and gets a field of view, and we switch on this application, it should be able to automatically scan the smear and give you a verdict on whether the structure of interest, in this case, malaria parasites, are present or not. And we are going ahead to see whether it should be able to quantify parastemia and finally give information in a kind of linked to a central point where I say, from this particular center, malaria diagnosis was made using a smear, and the result was positive. So that it gives surveillance results or prevalence results in real time. That's the kind of automation that we have been working on, and that is what we are now ready to test in the field in the next couple of weeks. Recently, we did some surveys around the country to assess the infrastructure needs and also to be able to seek the views of different health managers, starting from the DHOs to the facility managers and the lab people in these facilities.
Dr. Andrew, have we
What
lost
your
you?
views will be. Yeah. Are you guys still able to hear me?
Yes, Alfred.
Right. Thank you. Thank you so much, Dennis. Yeah. So I don't know, Rose, are you able to make your presentation now? Daphne, have you been able to reach out to Rose on her phone?
I have, yes.
Yeah. So as she gets, I think she's getting challenges sharing her slides and so on. So this is the basics about this particular approach. And I know there are fellows who are from computer engineering who are part of this team, software engineering part of the team, and they can be able to present the principle of operation of this particular application. Is there any, either Henry or Jeremy, are you able to talk to this briefly to give the audience the context of this? Then maybe if they have any questions, we can be able to discuss them. I don't know what you think, Daphne, with that approach.
That's fine.
I saw Jeremy online.
Yeah, I see him too.
Anybody from the AI lab that,
Joe, Jeremy, anyone else? About to? I am not getting any feedback from you.
No,
Yes, doctor.
I think my network is really failing me. I don't know if we have either Jerry or Solomon on the call to give context from the AI lab. But can you see my screen right now? Because I'm trying to share.
Yes, we can.
And anyway, I drop off, I could request Jerry or Solomon to drop in. Thank you, Dr. Alfred, for taking us through the different sessions and giving us background to the work that we are
End of our discussion here. So I'll give a few minutes to anyone that has a question. I saw Success, was your question answered in the chat?
Hello, can you hear me?
Yes, we can.
I don't think it was clear more about they gave a background about the project, but I still wanted to find out how would it compare with the new RDCs that is rapid diagnostic test, most especially in the rural areas, because I feel probably these are cheaper, and that's why they're picking up the trend. Yes, I probably know that we need the technologies to interpret and what to do. So I wanted to get that picture clear. How would AI compare with the existing, most especially the rapid diagnostic test for the malaria test? Yeah.
All right. Dr. Andam, are you able to answer, or do we just want to get the batch of questions and then kind of just going to answering? Is there anyone else that might have any questions or comments as well? You can share in the chat as well. I'll be able to read them out. Right. In the meantime, Dr. Andama, can you take this? In terms of accessibility, cost, and availability, how does the use of AI compare to RDTs, especially in rural areas?
Right. Thank you so much for that question. Why we chose microscopy, because this still remains the gold standard. And it was easier to, since microscopes that time were widely available in most health facility laboratories up to level 3. That's where we zeroed on microscopy. Yeah, I agree. At some level, you find RDTs actually the order of the day, supplementing the microscopy. So we have not done a deliberate study to compare the performance of the AI platform with the RDTs. So in our next move, where we recently collected data on the infrastructure from health facilities, we want to look at that aspect as well. If there are RDTs, how do they compare with the AI and also the microscopy? What we also realized was that in some of the facilities where we collected data about 2 or 3 weeks ago, there were also frequent stockouts of RDTs. So we hope during our pilot phase, we'll be able to find a couple of facilities where both microscopy and RDT are being done concurrently. Then we'll add the AI, then do a comparison for the 3 methods. Yeah, so I don't know whether that answers your question.
Yes, it does. Thank you very much.
Okay, thank you.
All right. Anyone else before we close this discussion? From Dan or team, are your data sets publicly available, and do you leverage publicly available data sets too? I see Jerry or Solomon are able to take this on.
Thank you, Daphne. Yes, so the data sets are available for researchers to use. And I think I'll put the link in the chat. So if you go to the Macquarie AI Lab website, the data sets that you can use from there. But I'll put the link in the chat.
All right, thank you, Solomon. Simon Peter Mwesigwa, has the project done feasibility assessment in terms of adaptability, capacity, and resource requirements for the use of this innovation, especially for rural areas? Yes, I think Dr. You can give Dr. Andama, you can give basically your insights from the field visit. Was it this month?
One of the things we did this month actually was that kind of feasibility assessment. We picked health center 4, health center 3, health center 4, then a hospital, and we were looking at regional referral hospitals. So in summary, we found that most of these facilities had at least one lab tech, and each one of them had at least a microscope functional, and most of them had the Olympus type of microscope, of course, with the different versions. And a few, over 90%, maybe 95% of the lab techs in those facilities had a smartphone. So we just think in terms of infrastructure and leveraging on what is already in those labs. I think these were the basic things. and the labs were relatively spacious to be able to do that kind of work, especially at health center level 3. Now, in terms of whether there were the people were willing to embrace this approach, yes, because most of these people, these lab techs who have had smartphones, were already doing a lot of applications for different utilities on their phone. So when we suggested to them that actually this approach could use a smartphone and they already had their smartphones, then they were eager to see how artificial intelligence in their phone or on their microscope and be able to make a diagnosis and leave them time to do other things. They sounded like they were excited. And that's the strength that we are going to build on in order to improve whatever we were set out to do in the field.
Thank you, Dr. Andama, for that. Dan, I think someone has answered your question on the available datasets. Kindly just check the chat for that. Tadeo, do you mind just unmuting your mic and asking your question? I'm not really getting it well. I wouldn't want to misrepresent.
Right, thank you. So the question is this categorized as an SMD, which is a software as a medical device? And did you do pilots on this? And the last one is NDA involved, and at what capacities is NDA involved?
NDA is
The National Drug Authority.
NDA, got it.
Yeah.
Can I just, Daphne, I know we are at the top of the hour. I just wanted to give my view. This particular application is not a device. A device is a structure in terms of the definition from NDA, is a structure that you apply directly or indirectly on a patient. We are currently evaluating different devices. If it is something that you are going to apply on a patient, then NDA becomes so close to understanding how it is going to affect the patient. But here we're looking at improving already an approved system. We are doing studies to see if we added something onto a standard structure, will it improve outcome? So at an appropriate point where this application has shown accuracy across different facility levels around the country, then we shall get this data on the advice of the malaria control program at the Ministry of Health to be able to showcase that this is what we set out to do, this is what we found, then what do we need to do in order to incorporate this into the system that already in existence. So NDA, yes, will need to be aware, but since this is a software that's not going to be added onto a smartphone and improves microscopy, I will just need to, National Drug Authority deals with the drugs and devices. So we shall need to discuss with NDA and see whether there's anything that they think compromises patient safety. Actually, that's their main concern. Will the AI compromise patient safety should be the question. And if the answer is yes, then we need to identify those specific aspects that play into that. Then if not that, if it doesn't really compromise, and the decision is still based on the clinician's judgment on recommending a diagnostic approach, then dialogue is always the best way to go. But let's first get this done, then we look into the next legal and regulatory aspects.
Okay, that's well answered. Thank you.
All right, we are at the top of the hour now. I'm hoping that's the questions that we have for now. I'd like to thank Dr. Andama for taking us through and representing very well on behalf of Ocular. I would also kindly request the participants here, if you haven't already, kindly do follow us on Twitter, on X, Twitter, and on LinkedIn. You'll get regular updates on the different engagements, forums that we will be a part of in the coming months. Yes, that is it. I'm hoping I'll be able to share this recording for those that attended as well. Thank you for your patience, and also sincere apologies for the technical mishaps. Yes, we are hoping to, this is the first of many, and we will be able to improve on the flow of the presentations and all. Yes, have a good afternoon and a happy Easter to everyone.